It's clearly been an area that, after lying dormant for a decade, has exploded in the last 5 to 6 years with development of targeted therapies that we combine with standard of care endocrine therapy. And it's translated into enormous clinical benefit for our patients. The initial development of everolimus was certainly a step forward and a rationally designed target with a modest clinical benefit. But then, to me, having come out of a cell cycle lab and doing research as a fellow, to see the cell cycle machinery finally being targeted in a very specific fashion and combined with endocrine therapy, and exploiting this observation that was made a good 15 years ago about cyclin D amplification events in ER-positive disease, contrasting that with some of the alterations in other cyclins and other subtypes of breast cancer, like cyclin E amplifications in ER-negative disease, it really begins to point to a different part of the biology of cancer that we've known has been critical and at the very heart of oncology for a long time, but just haven't known how to target it. So to see those drugs come forward, to see palbociclib demonstrate this doubling of progression-free survival with a fairly modest toxicity of neutropenia, which all oncologists are quite comfortable in dealing with, is just been very satisfying. I think the next steps and how we can combine these targeted therapies together in unique combinations, and knowing how to sequence those, knowing how to use the right platforms for assessing the underlying molecular alterations to really pick those agents in the appropriate patient population, is really where we need to go next. And it's going to be a very exciting time working through all that biology.